We have a few people who are joining us virtually. There's a form that's in front of you that you'll need to keep. And following this presentation, sometime in the next week, we'll send you an email that has an evaluation. You fill out the evaluation. We'll send you the paperwork, the remaining steps to cash in your CME or your CME. This is the AIDS Education Training Center lecture. The AIDS Education Training Center is tasked with disseminating relevant, timely information about HIV/AIDS care. It's funded by HRSA through the AETC that's based in Parkland. It's an honor to have Dr. Phil Kaiser here with us today. He has led numerous randomized clinical trials to design and assess the best treatment options for people living with HIV. He's been active profusely across Texas, across the United States, and even running and consulting with major programs in Kenya and elsewhere. So it's a very big honor, Dr. Kaiser, to have you. We look forward to your discussion of treatment guidelines on initiating ART for adults.
Thank you. Thank you very much. I'm just really happy to be here. You know, one of the things is that when you deal with a live audience and then you have people on the web, you always have to be worried about, you know, who you're looking at and who you're talking to, you know. I don't know if you ever watched Joel Osteen on TV. There are times, you know, you see him cut away and then he's talking like this. And then there are times like he's like talking right to you. But what he does is he actually walks, let me get this right, he actually walks right up to the camera and stares into the camera as he's being so passionate, you know. And it's, if you actually could see that from the side, it would look very, very artificial and a little silly. But what we're going to talk about today is HIV treatment guidelines. And this is important because there are a lot of drugs to treat HIV infection. And now we're coming up on 2016. We're coming up on our 20th year of highly active antiretroviral therapy. And for those of us that were around then and treating people then, it was an amazing time. It was amazing because young men who were dying stopped dying. Just like that. And it was that fast. We'd give these people these drugs. We thought they were going to die. They'd come back in a couple weeks later, and they're doing better. And a couple weeks more later, they're doing better. We used to call it the Lazarus syndrome, people rising from the dead, because it was just so dramatic. The problem was that these drugs were hard to take. They had a lot of toxicity. They had to take like 20, 30 pills a day. And it was really, really hard for people to take the meds and take them for long periods of time. But over the years, our regimens have gotten better, things have gotten a lot more simpler, and it's actually become pretty easy to treat people with HIV. We're now at a point where we can treat people with one pill once a day. Just as we've gone through this whole era of HIV protease inhibitors, just in the past couple of years, we've really entered another era, and that's the new class of drugs that we call integrase inhibitors. And what I hope to make an argument for you today is that these drugs actually are superior to the agents that we had used in the past, and that we should be using them. They're superior in that they have better antiviral activity. They're superior in that they have less toxicity. Okay. So what I'm going to do is I'm going to put this in the context of treatment guidelines. And the reason why treatment guidelines is because because there are so many drugs out there and there's so many ways you can do it, the federal government issues a set of guidelines to use to treat HIV infection. And these are meant exactly as I said. They're like guidelines. So I don't know how many of you remember seeing Pirates of the Caribbean. And there's a very classic period of time where the heroine invokes the pirate code. And by the pirate code, you have to do this, 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 and the other thing. And the old pirate answers, well, yes, I understand what you're saying, but you didn't do this, you did do this, and this. And besides, they're really more like guidelines, you know. So these aren't laws, but they're good principles on which to practice because they're based on evidence. And so what I'm going to do today, first of all, is talk a little bit about HIV virology, just a very little bit about the HIV life cycle, and then show you how these drugs, or the sites in this life cycle where these drugs work, so that kind of gives you a little bit of context. And then we'll actually start talking about the drugs and things you have to do when you first start treating people with HIV to work them up, and then actually look at some of the data and then have some closing things. It's really not very long. The whole thing probably will take, about 25, 30 minutes. We've got about 30 slides, and hopefully it'll be enough that you can get something out of it. So the first thing we're going to do is we're going to look at the HIV life cycle. So this is a little cartoon of a CD4 cell. And so the blue is the cytoplasm of the CD4 cell, and in the center you see a nucleus, and all that green stuff, that's supposed to represent DNA. And so HIV looks like this little star here. It comes and it binds to the membrane of the CD4 cell. And then after going into the membrane of the CD4 cell, it fuses with it, and it releases its genetic material. Now, HIV is a retrovirus, meaning that it encodes its genetic material as RNA. For us, we encode our genetic material as DNA. Most species encode their genetic material as DNA. Some viruses don't, and HIV is one that actually encodes it as RNA. But the reason why it's called a retrovirus is because it then takes that RNA and makes a single strand of DNA from it, and then makes a double strand of DNA from it. So now it's converted that RNA to DNA, and then that DNA is transported to the nucleus of the cell, where it gets incorporated inside to the cell's genome. So it gets into the DNA of the person who has it. Now, once that happens, that cell's permanently infected. And we do not have the technology today to get that DNA out of the cell. And that's why HIV is essentially an incurable disease. Because while we can suppress it, we can't actually get the DNA out. So someone, once they're infected, with our current technology and our current ability to do things, they're going to stay infected. Now, that doesn't mean somebody in some period of time is not going to come along and figure out a way to get that out. But it may take a long time. Once HIV has incorporated its DNA into the host DNA, it takes over the cellular machinery. And then the first thing it does is it makes some more RNA. And then that RNA is used to make, some of that RNA is used to be genetic material for future viruses, and some of it makes proteins. And HIV actually makes its proteins as a single long protein. In humans, we make a whole bunch of different proteins at the same time. In HIV, it's just one single long protein. And then an HIV protease cuts that protein up into little pieces, and then it forms around the HIV RNA, and it makes a viral capsid, which then goes out and infects another cell. Now, the reality is that this is not a one virus in, one virus out phenomenon. When you get one virus in, you literally can get millions of viruses out of a single cell. And during that process, it just disrupts the cell membrane, and the CD4 counts start to decline. All right. How does HIV cause disease? Well, it causes disease by interrupting the growth of CD4 cells by destroying them. And so you can see in this graph here, what you see in the red line is the HIV RNA. So this is, say, someone first gets infected with HIV, I was drunk, she looked good to me. It's a sexually transmitted disease. That's how people get it, okay? And then they have this burst of viremia, and during that burst of viremia, they start having symptoms. And the symptoms can be very much like a viral illness. They can have a sore throat, they can have swollen glands, they might have a rash, they might have a little hepatitis. But the bottom line is that it looks like mono, it looks like a lot of other viruses that people get. And when they go to their doctor, they say, I don't know what's wrong with me. And the doctor goes, you have a virus. Actually, one of our former fellows, Dr. Sophia Ansari, some of you know her, called me up telling me about this guy who came in, young gay man, came in, all these symptoms. She sent his HIV test. It was negative. And she sent off an HIV RNA, and it was through the roof. And she diagnosed him with acute HIV. And he told her, well, I went to my doctor, and he told me I just had a virus. And she said, you do. And so that's the thing. It is a virus, and they get sick. But then what happens is that the immune system kicks in, and then the virus gets pushed into the cells and gets pushed into the reticular endothelial system, and then you have this persistent level of viremia. And during that period of time, the CD4 initially rebounds, but then it goes down, 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 down. And then once your CD4 count gets below a certain level, you start getting a variety of infections. When you get pneumococcal pneumonia and herpes, when it gets around 350, when you get to 200, you get PCP. When it's less than 100, you get toxo. When it's less than 150, you can get max CMV, and then you die. All right, that's the natural history of HIV. Time from diagnosis or from infection to death, on average, is about 11 and a half years. People have this virus for a long time before they start getting sick. And that gives people a lot of time to spread it to other people, which is why we have a worldwide HIV epidemic. It's very interesting. You look at Ebola, you know, Ebola makes people sick really fast. And not only makes them sick really fast, people around them die really quickly, you know. And so what happens during an Ebola outbreak, you know, a couple people get Ebola, everyone else runs. The virus doesn't have any place to go. This time it was different because the outbreak actually occurred in a big city where people were on top of each other, and so a lot more people got infected, and it was allowed to sustain itself. But even so, the Ebola outbreak's been contained, not through anything anybody's done. You know, it's just a matter of kind of getting all the people who have it and put them in one spot. HIV, you can have HIV for years, you can spread it happily and don't know about it for a long time. Okay, now how can we treat HIV? We got a lot of drugs to treat HIV infection. And so going back to our cartoon here, we have entry inhibitors that inhibit HIV binding to the cell and also fusing to the cell. We have what are called HIV reverse transcriptase inhibitors. They inhibit HIV being converted from RNA to DNA. And the classic one, of course, is AZT. And that actually gets and interferes with DNA synthesis. And then we have things called non-nucleoside reverse transcriptase inhibitors. And these are drugs that enzymatically inhibit the HIV reverse transcriptase. And then we have integrase inhibitors. And I remember when I first started talking about, when I first made this slide, it's actually pretty old, we were talking about HIV integrase inhibitors, but we didn't really have any clinically. But now that's one of the mainstays of our therapy because we use them a lot because they work so well. So we have HIV integrase inhibitors that keep the HIV DNA from getting incorporated, and then the HIV protease inhibitors that keep this protein from being chopped up into little pieces and prevent viral assembly. And those were the drugs that 20 years ago really revolutionized HIV care. Now, one of the most important things to understand is with HIV is that the amount of virus that you have in the blood does in fact predict how rapidly you'll get sick. And you think about it, it makes sense. If for whatever reason, because of this particular virus you have, or because of the way your immune system reacts to the virus, you have a little bit of virus, you're going to get sick slowly. You have a lot of virus, you're going to get sick really fast, right? And so this was a study that was done many years ago where it looked at patients based on their baseline viral load and how rapidly they developed AIDS. And you can see that if you had almost no virus, only 8% of those people progressed to AIDS. If you had a little bit of virus, 26% of them. More, 50% of them. And once you had over about 100,000, those 62% of those people progressed to AIDS in a very short period of time. Now, I'm not going to show you the data on this, but I'll just tell you that what we found out over the years is that if you can get someone's viral load to this point, down to that point, they're going to progress very slowly. And if you can get it down to the point where you can't detect it at all, you're not going to die from HIV. All right? And we have seen this over and over and over again. Currently, for people who are taking medicine and are coming to the clinic and taking care of themselves, the life expectancy of someone with HIV is almost about the same as someone who doesn't have HIV. It's actually very similar to what you would expect to see in someone who has treated diabetes, a diabetic that's well controlled. So, you know, if you have diabetes that's out of control, it's really going to shorten your lifespan. But it's well controlled. Diabetes will probably take about 3 to 5 years off your expected lifespan. And that's according to the modeling of what we think is happening with HIV. Now, the problem is we've only got 20 years experience, right? So, you know, we need another 30 or 40 years before we can really say that definitively. But so far, the key is to get the viral load under good control and have people responding to therapy. Now, when someone comes in and we first diagnose them with HIV, there's a series of tests that we always do as a baseline test. We get a CD4 count, and remember the CD4 count measures where you are in that disease process. The lower your CD4 count is, the more likely you are to get sick, and that helps us stage them, how to figure out, you know, where they are. We get a viral load test, And we measure how much virus is in the blood. And again, we've shown you how important that is. If your viral load's high, you're more likely to not do well. But we also want to monitor how low does the viral load go. Can we get the viral load undetectable? We also do resistance testing. I'm not going to talk a whole lot about this yet, but remember, we've had these HIV drugs for over 20 years, and we're beginning to see resistance. And so for a drug that we used to use very commonly called efavirenz or Systiva, about 7 to 10% of newly diagnosed HIV patients, even though they've never taken an HIV drug, have resistance to that drug. Now, how do they get resistance to that drug? Well, you know, they have a buddy who's taking the drug and not using it, you know, and they have sex and they get the virus, and sure enough, they get a resistant virus. And so that's why it's very, very important to do a resistance test. Sometimes we see resistance to the AZT-like drugs. Sometimes we see resistance to the protease inhibitors, but particularly with the non-nucleosides, we see a lot of resistance. It's important to get a CBC, see whether people are anemic. We get a BUN and creatinine because some of the drugs can affect renal function. We get hepatitis serology. We check their LFTs, and then we also do an HLA-B5701 test. And an HLA-B5701 test is a test that measures an allergy to a drug called abacavir. And you're going to hear a little bit more about that. And the reason why it's important is about 5 to 7% of white people of Northern European origin have an allergy to this particular drug. And it's a kind of a funny allergy. If you take it about 7 to 10 days after starting to take the drug, you develop fever, you develop muscle aches, you can develop a rash, you can have some nausea and vomiting. You keep taking it, you get sicker. You keep taking it, you get sicker. You keep taking it, you can die. And if you have the hypersensitivity and you go off the drug and you go back on it again, it can kill you very quickly. It can actually be like an IgE-mediated response. So what we do is we look to see if people have a certain genetic predisposition through this HLA-B5701 test, and if they don't, you can give them the drug with impunity. It's very interesting. I just came back from Kenya and Sub-Saharan Africa. Nobody does this test because Africans don't have it. All right. And generally, if you look at maps, if you plot it out, it really is something that the farther south you go, and as people's skin color gets darker, you see it less and less and less. And it really seems, this locus really seems to focus in the descendants of Scotch-Irish criminals that were deported to Western Australia. So it's really, Northern European, Scottish, Irish, Nordic. And of course, the British, when they lost the Americas, they started sending all their criminals to Australia as opposed to sending them here. And so those are very genetically pure populations, particularly when you get out in Western Australia, because not a lot of people go there. And so there's a high propensity of those folks. Among Americans, like I say, it's about 7 to 8% among white people, about 2.5% among black folks. Among Mexican Americans, we really have no clue. And among Asians, again, really don't see it very much at all. So it really seems to be focused in that group. Nevertheless, this is America. We believe in equal access, so we test everybody, okay? Just in case, grandma had a friend that you never knew about. When we start, we get all that stuff done, we're in a setting where we can start to treat HIV infection. And when to start, the evidence actually supports starting at a high CD4 count. And it's currently recommended that we should treat everybody unless you have a reason not to. It doesn't say that in the recommendations, like unless you have a reason not to. That's my editorial comment. But you want to get people on drug, because they do better. And I'm going to show you that in just a minute. And the reasons not to are reasons like they're doing a lot of drugs, they're drinking a lot, and they're not going to take the medicine, they're just going to get resistant. They may not have a stable home setting, and I mean really unstable home setting. They may be living on the streets. They may not have a way that they can keep the drugs and do what they need to do. They may have a lot of mental illness and gets it in the way. And so there are lots of reasons why we tend to wait. We try and get people sorted out before we actually start the medicine. But it isn't the idea that you're not worthy of getting on medication. It's that it's not a good time for you, and we want to get stuff straightened out, but we can get on you. But for the most part now, we recommend treating everybody. And this is some of the data that goes in terms of why we start early versus not start early. This was a study where they looked at patients and they gave them either immediate antiretroviral therapy, okay, regardless of your CD4 count, or they deferred it. And deferred it meaning that they waited until your CD4 count met a predetermined criteria. In this case, I think it was 350. So they waited till your CD4 count drifted below 350. And then they asked the question, who died? Who got a serious infection? And how rapidly did that happen? What you can see here is, look, these are the numbers of people, cumulative events. This is the deferred antiretroviral group. This is the immediate antiretroviral group. You can see it's almost half as likely, right? And there's actually been large database studies where instead of enrolling people in a clinical trial, you just take all the data from very large clinical databases looking at over 100,000 patients, and it finds that no matter what CD4 count you're looking at, whether it's above 500, 500 to 350, less than 350, 350 to 200, it doesn't matter. The higher you start the CD4 count, the better people do. Now, the outcomes, interestingly, these events really are variable depending on what their CD4 count is. So if you have a low CD4 count of about 200, you're more likely to get an opportunistic infection, right? But interestingly, your CD4 count's above the level where you get an opportunistic infection, say around 400 or 500. Those people, if you don't start them on antiretroviral therapy, more likely to have a heart attack. They're more likely to have progression of their chronic liver disease. All things that are inflammatory related. So there's a lot of inflammation that goes on when people have HIV infection. And by treating the virus, you reduce that inflammation and you make it less likely that they'll get sick. So this is a list of the currently, I don't know what I was going to say, available, let's see, yeah, currently available HIV medications. The reason why I was just looking for one that I know was taken off the market, and sure enough, it's not on that list. You know, we got a bunch of fellows here sitting in the back, see murderers row right there, right? I don't know how you guys look at this and do it. I really don't. I mean, because for me, I learned each one of these drugs one at a time. I graduated from medical school in 1986, and guess what? 1986 was the year AZT came out, okay? And so we use these drugs one at a time, and I can honestly say there's not a drug on this list that I haven't used or misused during my career. But you look at this and you go, oh my God, how can I possibly learn all these drugs and learn what to do about these drugs? And the answer is you don't have to, okay? There's some of the drugs on these lists, basically there's very little reason why we should ever use them again, all right? And some of them I honestly don't know why they're on the market. This drug here, for example, Topranavir, we stopped using that about 10 years ago. One, because there was a better drug available, and two, because it had a lot of side effects. And not only side effects from HIV, but people were getting strokes and people were getting pulmonary embolus because they developed clots in their legs from the drug. You know, DDI. Main reason to keep it is for pediatric doses. But if you use this drug, it gives people peripheral neuropathy, makes their hands and feet tingle and then hurt. And you know, I would have one patient, I could tell how his peripheral neuropathy was doing by whether he wore open-toed shoes or whether he came to clinic in slippers because it hurt his feet so much. The other problem with DDI, if you drink DDI and you drink, you can cause pancreatitis. And I can tell you, we've killed some people by giving them, not recognizing that your alcoholism's bad, and if I give you this drug, something bad's going to happen to you. So some of these drugs we just don't use anymore. And so because of all of these drugs, the federal government has come up with some treatment guidelines. And these are the guidelines that they come up with. So there's a lot of slang here that I'm going to walk you through. But basically, they come into, the treatment guidelines say, we want you to put people on the drugs that have the most potency, that have the least amount of side effects, that are the easiest to take from a palatability point of view, okay? So do you know what I mean when I say palatability of a pill? How many of you take pills regularly? All right, you know, so you have big pills, little pills. How many people like to take big pills? All right, how many of you like to take pills that don't go down very easily? How many of you like to take pills that make your stomach upset? No, right? You know, so that sort of sense of, does it, you know, is it easy to take, literally physically easy to take? And we run into that problem because we've had some pills, they go in the back of people's mouth, the saliva gets in it, they foam up and they make them gag. We have other pills that just taste terrible. We have some medicine that give people nausea and vomiting. So the whole idea is to get people on medications that are less likely to cause them severe problems. And they fall into two classes. They fall into what they call, I actually don't know, something integrate. I don't know what this abbreviation stands for, but basically they're integrase inhibitors, okay? These are the things that keep the HIV DNA from getting into the cell. And there are two of them that are important. The first one is called dolutegravir, okay? And then the second one is called elvitegravir. Okay, so just think of Elvis when you're trying to remember elvitegravir. Dolutegravir, I haven't come up with a good way to remember it yet. But so you'll see here it's dolutegravir, DTG, dolutegravir, TTG, elvitegravir, elvitegravir. Okay. They also include raltegravir. That was the first protease integrase inhibitor on the market. Quite frankly, I wouldn't mess with that. They leave that there because there's like a political contingent that likes it. But it's a twice-a-day drug, and all the other ones are once a day. So dolutegravir, elvitegravir are once a day. Okay. And then you can combine dolutegravir with abacavir. Remember, that's the one that gives you the allergy, or 3TC. And 3TC. And so 3TC is another AZT-like drug. So it's two AZT-like drugs plus the integrase, but only do that if they're HLA-B5701 negative, i.e. they don't have that allergy, okay? Which is about, 95% of the people, all right? Or if they have the allergy, you can give them dolutegravir plus tenofovir and FTC. And FTC and 3TC are basically the same, so it's a little confusing, but this is different than the abacavir. So this is good for people who do have the allergy. Now, one of the problems with tenofovir is that it can cause kidney failure and it can cause people's bones to thin out. But the company that makes this has actually just come out with a new product where it doesn't cause kidney failure and it doesn't cause osteoporosis. All right? And so that problem's going away. The other option you have is you can use elvitegravir, tenofovir, and FTC. See, you see those right there. And you see this thing, it says only use if their creatinine clearance is greater than 70. Okay? And then elvitegravir, here they call this TAF. It's basically the same drug as this, but this is the one that doesn't, this is the version that doesn't give you kidney failure. And the reasons why there are two of them on the list is because the company's still kind of getting, they're transitioning over to the new formulation. Not all insurance companies have it yet, so they're still making both available. You can use that if someone has really bad kidneys, okay? These drugs work extremely well. The other drug that they also said to consider, use darunavir, use tenofovir, and FTC. So darunavir is an HIV protease inhibitor. The downside of the darunavir is that it has more side effects. It causes more nausea, more vomiting, more diarrhea, all right, and just makes people feel funny. Not everybody can take this drug. Not everybody has a problem with it. We got a lot of patients who take this drug, and it's like, yeah, it's fine, no problem. But not everybody can take this drug, okay? So what's some of the data? One of the things I think it's important is that you need to use as small and as little pills as possible. Of the regimens that I showed you, this one, and this one are available as single tablet regimens. This one, you got to take an 800 milligram pill here, you got to take another pill there, you got to take 2 pills. You got to take at least 3 pills a day. Here you got to take this one twice a day, plus this once a day. Here you have to take 1 pill, and then this is another combination that's 1 pill. So, how many of you want to take the 3-drug regimen? How many of you want to take the 2-drug regimen? How many of you want to take the 1-drug regimen? How many of you don't care how many pills you take? Yeah, right. There's some people that don't care, right? It doesn't matter. Some people, it's a huge deal. Any amount of pills you want to give them is a huge deal. And so you have to be sensitive to that sort of thing as we prescribe drugs for the patients, okay? And so this is our goal. 1 pill once a day for everybody, all right? And believe it or not, we've actually got a lot of drugs that can do that. And some of the best drugs we have available, you can give 1 pill once a day. Okay, so how do we know these drugs work so well? So In 1999, there was a medication called efavirenz, which I told you is already developing, that resistance is developing to, came out. And this was a drug you could take once a day. It was very potent, and we were actually able to make it into a single tablet regimen over time. So you only took one pill once a day with 2 other drugs in it. And so that drug became the standard of care. And what the FDA requires is that anytime you start a new drug, you get a new drug approved, you have to compare it against the gold standard. So everything got compared to efavirenz. And from 1999 until 2013, late 2013, no drug ever beat efavirenz. I mean, scores and scores of trials done. Some did just as well, a lot did not nearly as well. But then, in 2013, this drug called Triumeq, which is dolutegravir, abacavir, and 3-TC, they compared it to tenofovir, FTC, and efavirenz, and look what happened. These are the people who got on efavirenz. These are the people that got on dolutegravir. And you can see that the proportion of people who have an undetectable viral load is different. And this was better, and not only better, it was consistently better, and the difference was statistically significant. And that was a big deal. This slide also shows you something about the way integrase inhibitors work. So this is someone's viral load. The portion of people have an undetectable viral load, and you can see that most people have an undetectable viral load at about 24 weeks, or about 6 months. When you look at dolutegravir, the first measurement at 4 weeks, most people have an undetectable viral load. So it's much more potent, gets the viral load down, and that actually translates into a clinical advantage, and that people do better. What about side effects? Well, side effects of efavirenz are that it makes people dizzy, it makes them feel sort of unreal, like things aren't right. It gives people very, very vivid dreams. And sometimes these dreams are very disturbing. I mean, imagine you just got told that you have a potentially life-threatening disease. And then we start you on a medication that gives you various dreams. I've had patients come in and tell me about nightmares that they've had, where they dreamed they were dead. They saw themselves in their coffin. It was really, very, really, very scary. I've had patients who've had funny dreams. I had one patient who used to watch pornographic movies before he went to bed, and he would dream he was the star of his own porno movie. I'm serious. We were sitting there, you know, like at the table. He's telling me about this. That wasn't the problem. The problem was that these side effects usually go away after about a month or 2, and his dreams went away, and he wanted them back. And he's literally pounding the table. I want them back. So I explained to him, no, that it doesn't work that way. You know, your body's gotten used to the drug, and so you're not going to have the side effect anymore. But he was a thoughtful guy, and he goes, hey, how about I stop taking it for a while, and then I start taking them again? And I go, no, don't do that, because that's the way you get resistance to it, and the drugs will stop working. No. He was very upset with me. He left. I never saw him again. I don't know what happened to him, and I don't know. Maybe he's a porn star in LA somewhere. I have no idea. But you know, sometimes people have they have odd dreams. Sometimes people like the dreams, but for the most part, people don't like feeling weird, and so you have more side effects with this. With dolutegravir, number 1 side effect: headache, 2%. Okay, insomnia, 2%. Okay. When you look at reasons why people stop the drug, those were the reasons, right? And when you think about a general population where you have, you know, almost 1,000 people in it, that you have 2% of the people say they have a headache, or that 2% of the people say that they have you know, they can't sleep well. I suspect if we polled this audience, we'd have more than 2% of the people who said they couldn't sleep well, starting with me. So, you know, it's hard to say that that's really attributable to the drug. Here's another example of dolutegravir. So abacavir, dolutegravir versus 3-TC versus abacavir, 3-TC, darunavir. Remember that protease inhibitor, right? This used to be a drug that's in fact, still very widely used. But look, you see the difference? Statistically significant. P-value of 0.025. Look at the number of people undetectable at 4 weeks. It takes 24 weeks to get the same amount with a protease inhibitor. Similar issues with side effects. Darunavir, nausea, vomiting, diarrhea, makes your lipids go up. Sometimes people just really don't like to take it because it makes them feel bad. Here's one, a Stribild. So this is elvitegravir. All right, this is another one of the recommended things compared to atazanavir, which is a protease inhibitor that's no longer on that list of preferred agent. It used to be a preferred agent. It's no longer on that list. Why not? Because when they compare it to elvitegravir, 90% versus 87%, 82 versus 83, and then when you look at the side effects, much higher side effect profile. I remember when atazanavir came out, we were real excited about it. It had so little side effects, didn't screw with the lipids, it's going to be a great drug. Well, it didn't turn out to be. It actually was a good drug. We saved a lot of people's lives with it. But now we have better drugs, okay? So what we've done is we've really entered in to the integrase era. And one of the things that we've done in the past in terms of treating people with new drugs is that if someone's doing well on an old drug, we don't mess with it, all right? You know, if it ain't broke, don't fix it. So I take medicine for my lipids, and I take some medicine for diabetes, and I went and got a new primary care provider, and she said, oh, why don't we do this, and this? And I said, look, you know, for most of my adult life, my cholesterol was high, I couldn't do this. I finally found an endocrinologist, and we experiment a lot, and I just go in these little doses of these little drugs, and everything's fine, and I don't want to mess with it, right? You know, and that's the way most people are, okay? And that's the way I generally practice medicine. But I got to tell you, we have data now. If you take people off their protease inhibitor and you take them off their efavirenz and you put them on an integrase inhibitor, they do better. They have less side effects. They have less toxicity. They stay on the drug better, longer periods of time. And here's just an example of that. So here's a study where they looked at dolutegravir, 3-TC, and abacavir, and they put people on the drug. In this particular study, they showed no harm being done. But when you look at patients who are on elvitegravir or Stribild, they actually did a lot better. So, and when you put all the data together, it makes a lot of sense. This shows you all the switch studies that have been done, okay? So raltegravir, efavirenz, you know. So check means that it favored switching them off their drug onto a new drug. So here we're looking at switching them to elvitegravir, here switching them to raltegravir, here elvitegravir, dolutegravir, elvitegravir. And the bottom line, these are the only ones where it didn't show much benefit in switching. And what do all of these things have in common up here? Except for a couple, they're all integrase inhibitors. They're all these integrase inhibitors, which we can give once a day, have no side effects, very little side effects, and are very potent. And so, for the first time in my career, I'm actually looking for reasons to take people off their drugs. And I said to them, hey, how'd you like to get on a different drug? Well, I don't know about that. And I said, well, here's something to read about. Just think about it. You know, we're not going to twist anybody's arm and make people do stuff they don't want to do. But for the first time, I really am looking for reasons to switch because these drugs seem to work so much better. Okay. So when you start people on medicine, what are the things you have to think about when you start people on the drugs? There's a lot you got to think about. And at this point, you know, a lot of it, we've done it for so long, we kind of do it without thinking. It just kind of, no, that's not a good drug for you. Well, how do you know? Just trust me. I know. It ain't going to work. And so the patient characteristics in terms of what their CD4 count and viral load, do they have resistance? If they have resistance at baseline, you got to change what you're going to put them on. Do they have an HLA-B5701? Are they positive? Are they going to have an allergy to some of the medicine? You don't want to use that drug. What are their preferences? What is their anticipated adherence? You know? So for the most part, there are some people, you give them complex regimens, they can take it. All right? Other people, And most people do better with fewer pills. Do they have comorbidities? Do they have heart disease? Do they have kidney disease? Do they have psychiatric illness? Do they have co-infections with HCV or hepatitis B? Because if they're infected with hepatitis B, we got to give them some drugs that will treat the hepatitis B as well. If we're planning on treating their hepatitis C, we have to make sure we don't give them drugs that interact with the hepatitis C medications, and so we cause problems there. All right. Do they have osteoporosis? Are they likely to get osteoporosis? Well, certainly not only do we see women with osteoporosis, we're seeing men in their early 60s who have osteoporosis. and who have thinning of bones and who have fractures. And so that's something that you need to be concerned about. When you have psychiatric illness, you have to avoid using efavirenz because of all the CNS problems. Now, fortunately, we're not using that very much, but that's something you have to think about. When you have a high cardiac risk, you have to worry about abacavir. In some studies, abacavir has been linked with a high risk, with increasing, I'm sorry, not a high risk, but increasing the risk of cardiovascular disease, maybe about 1.5, 2 times. So, you know, in a young person, it's not a big deal. Someone like me, still probably not a big deal. You know, I have no history of heart disease, and my lipid numbers are good. On the other hand, if you get a guy who just comes out of the hospital who's had an MI and's got some stents and is on Plavix, maybe not such a good idea, right? So you have to consider looking at your risk factors in the patients. And then I already talked about HBV. We talked about hyperlipidemia, pregnancy, big issue in and of itself. One of the things with pregnancy that we always want to do is that when a woman gets pregnant, we want her on HIV drugs as soon as possible. The data is pretty clear. If you treat a woman while she's pregnant with HIV drugs, the chances of her getting, her transmitting HIV to her child is less than 0.1%, okay? When you talk to doctors who have those women that are in that 0.1%, you know what you find out? Oh, this woman, she was out on the street, she was doing cocaine, she came in active labor, she never had anything. And so I'm of the firm opinion that if you have a pregnant woman and she takes her meds, the risk of transmission is 0, all right? And I have no problem telling people that. And because if you take these drugs work, and if you take them, they work, and they work well. And, you know, pregnant women, no one is as compliant as they're two of the most compliant women and patients in the world are pregnant women, and that they do everything that you ask them to do, and a woman who does not want to get pregnant. They never miss their pills. It's never, did I take that today or not? I don't remember. If they really don't, hey, I'll miss them. So, you know, but it's very important to hold up that hope for the patients and let them know if you do this, everything's going to be okay. And when that happens, they are pretty much okay. So I think that's pretty much all I wanted to say. Oh, yeah, last thing. So the last thing we want to do is that we have patients on drug, and they're doing well. And then some patients fail. Now, 10 years ago, we used to have a lot of patients fail on drug. You had to take, you know, 15 pills a day, and you could miss some. It was much easier to miss a high proportion of your pills and develop resistance. Today, we have very little people that are truly failing their regimen. And what I mean by that is this, is that people come in, we measure their viral load's high. Why is your viral load high? Well, my viral load's high because I wasn't taking my meds, I ran out of meds, I forgot to get the stuff refilled, I got locked up and the jail wouldn't give me my meds, you know, I was out doing a binge, I was having a party, whatever, you know, I just don't like taking meds. Basically, they're not taking their meds, okay? It's very, very unusual in 2016 to have someone come in and say, I'm taking all of my medication and they have detectable virus, right? That's very, very unusual. 10, 15 years ago, that was a relatively common event. And then we would have to do something about it, so talk about what we would usually do. So one of the first important things is that you want to make sure the viral load is undetectable. And right now, that's at a level of under 50 copies, okay? So you want it below that point. Then there's this, that's called virologic suppression. There's also this concept of virologic failure, the inability to maintain viral loads of under 200 copies. Now, some people look at that, why is it different from here to here? And it really has to do with reliability of the assays of the test. Currently, when you look at all the ACTG studies, they don't use an under 50, they use an under 200 because what they've been able to show from a QA point of view, when they measure things in multiple labs over multiple periods of time, the number that comes up as reliable is 200. It's not under 50. And that mirrors what we see in clinical practice. We see people that are doing very well, and they come in one day and they have, you know, like 175 copies. You go, what should I do with that? Yeah, nothing. Let's see what happens next time. Next time they come in, it's undetectable. Okay? And that happens a lot, all right? It's when people are consistently sustained above that point, okay? So there are sometimes people have an incomplete virologic response. So they've been on drug for 6 months, 24 weeks, and their viral load's not undetectable. Usually one of two things is happening at that point. Either they're not taking their medicines consistently, or they had a resistant virus that we didn't pick up. And often the latter is that they have resistance. And so you go back and then you measure resistance in that person and you find resistance. More commonly, this is what we would see, which is a confirmed over 200 after being fully suppressed. But like I said, that doesn't happen very often these days. And the amazing thing is that with these integrase drugs, they don't develop resistance to the integrases very rapidly. It does happen, but it happens much less frequently. So if someone comes in and they haven't been taking their meds, they're taking it inconsistently, you say, here, go back on the same medicine you were taking. 15 years ago, that would have been heresy. You never do that. Oh my God, they're going to have resistance. They're going to everything. It's going to ruin their entire regimen. No, just go back on those meds. And you know what happens? Most of the time, they get undetectable, and everything does fine. Okay. So just to kind of sum things up, HIV can be very complicated, but because of the evolution of our drug therapies, and that every generation gets a little bit better, a little bit better, a little bit better, a little bit better. We're at the point now where you can take one pill once a day. We have various treatment options that are available as one pill once a day, depending on what the patient's needs are, that people, if you make the drugs simple to take and easy to take, people take them, and they do much better. And we have very few virologic rebounds, and people are doing extremely well. So actually, in some ways, it's a lot easier. It's not as intellectually challenging, but it's a lot more fun. You know, it's much nicer to sit there and tell somebody, you know, you're going to live a long life. And what I tell all my patients is that I want you to come to my funeral, and I plan on living a long time. Okay, and I've had a couple people say they'll take me up on it. So you'll have to tell me. I won't really be paying attention at the time. So that's pretty much all I have for you today, and I'll stop now and take any questions or comments or arguments. Actually, I once said that at a meeting, and some woman from Puerto Rico stood up and ripped me a new one. Man, she didn't like something I said. Well. Yeah, uh-huh. Sure. Yeah. Yeah, sure. So just, I mean, I think Jennifer has it. If, you know, if on the sign-in sheet, if you would just write down your email and make sure that we have it, and we can send it out to you. Or do we have everybody's email? Can we broadcast it?
Put it in like a Google Drive if you have the link.
Okay, and so that, yeah, so then if you want to go get it, you can link it. And, yeah. Yeah, sure. No problem. Be happy to do that. Yeah.
Did you do this lecture for the kaleidoscope?
For the what?
The kaleidoscope seminar for the inclusion?
I don't even know what that is.
Never mind.
Okay. Well, we should talk because we're looking for business. Okay. You had a question?
So I was in San Francisco back in the day.
Uh-huh. Yeah. Yeah.
And the cost was
Right. Right.
with all these new trying to combine drugs.
Yeah.
What's the cost?
Yeah. The cost in actual dollars, believe it or not, is not as expensive as people think it is. Although it's still a lot of money. Yeah. So the state of Texas has a program that's funded in part by the federal government, in part by the state. It's called the AIDS Drug Assistance Program. And we have about maybe about 15,000 people. And right now we're paying about $5,000 per person per year. Now, there are a lot of caveats with that because we're a big program, we're able to negotiate the best prices that you can possibly get. And the pharmaceutical companies will negotiate with us because they want us to use their drugs. Because for two reasons. One, they want us to use their drugs, but they also want other people to use their drugs. And when the state of Texas says, we're not using your drug because you're charging us too much money, all the other states go, oh, huh, I don't know. Those people in Texas say you're charging them too much money, you know, and if we're not sure we're going to put it on. So they're very keen to have us do that. So the bottom line is that there are ways to get people drug if they can't afford it. They have to jump through hoops. I would say the biggest problem that we face are those people who are working poor, who don't quite qualify to be on the state assistance, okay? And they're the biggest problem I think we have. We've certainly made a big effort to try and get people on the Affordable Care Act. Sometimes that works well, sometimes it doesn't work well. Depending on which plan they pick, they can get screwed. I mean, we had one guy who went from not having to pay anything on his meds. He made a little money. He was able to get on the Affordable Care Act. That's great. He got some copay assistance. That's great. And then his insurance company started charging him a $200 a month copay for his HIV meds. And it's like, I can't afford to do this, you know. And so we had to figure out some ways to deal with those issues as well. So it really, it's complicated, but for the most part, I think we can get most people on drug. And as a last resort, the pharmaceutical companies actually give us, they don't give us the medication, they give us, you know, vouchers for them to go to pharmacies where they can get the drug in emergency as well. But it costs a lot of money. Bottom line, it actually costs less money than it used to. One of the big problems we face from an institutional point of view is that if you have a pharmacy, and I used to work at Parkland, the number one line item on Parkland's budget was the pharmacy. And the number one item on the pharmacy budget were the HIV drugs. And of the top 10 drugs that they spent money on, 7 of them were HIV medication. So needless to say, we didn't get along too well because they always thought I was spending their money, and I was going, yeah, we're going to spend it. It actually, over the years, what happens, the relative price has decreased, and I think access is pretty good in the U.S. Yeah.
It's interesting, when you went through all the reasons to choose a drug, you didn't mention cost.
Right.
So I'm in a unique situation where I have to make a drug decision and I actually have to pay for the drug.
Yeah.
So would you change any of the recommendations on your protocol based upon that?
It's a hard question to answer. See, so I'm very familiar in terms of what the state pays for them. And I can tell you, the newer drugs, they cost less than the older drugs. The better drugs actually cost less, but we beat them up. You know, I mean, we don't make it easy for them. And they're real smart, too. They know that if they want to get their drug available, they've got to get those prices down to where we are. Because of all these wraparound services for the HIV. Now, I'm not talking about outside HIV, because, you know, even in our HIV patients who have non-HIV conditions, we face those issues. But with the HIV drugs themselves, generally we can find a way to pay for them, and we don't have to worry about the cost of the drugs. The other stuff, you know, we're struggling with hepatitis C right now. We're struggling with, you know, we struggle with psychiatric drugs. You know, I mean, all of it. It's very difficult. Yes.
So are you seeing new infections right now?
Sure.
What's the rate of transmission?
Sure. We're seeing new infections. The two areas where we're seeing a high rate of infection is in women in rural areas, particularly African American women. We have a fair amount of Hispanic women as well. It's very unusual to see white middle class women. Okay. And then we see it among young gay men, and particularly African American gay men are more common. We've had several Vietnamese folks come in recently, although my belief is that they probably got infected in Vietnam, and probably because of heroin use, although they're not telling us that, but it just kind of gives us that vibe. But those are the areas where we're seeing the biggest growth, and it's a real problem. Yeah. Right. Right. Right.
So do we expect to, and what is your rate of infection that you're aware of?
Mm-hmm.
The drug abuse?
Yeah, well, it depends on which drug you're using. So I did all my training in Baltimore, and in Baltimore has, how many of you ever seen The Wire? You ever seen that TV show about not very many folks? Yeah, it's a show about the drug trade in Baltimore. I can swear to you with hands held high, it's all true. Although the joke is, why don't Baltimoreans like The Wire? Because it makes them look like wimps. There's a huge drug trade, and it's primarily heroin. And so when I was doing all my training, it was heroin. Okay, and 90% of the heroin users in Baltimore have HIV. In fact, inner city Baltimore has HIV rates that rival many African countries and even higher than some African countries. When I moved down to Texas, it was really shocking to me because there it was gay men and crack cocaine. And so gay men, the drug of choice is crystal meth. Okay, it's a party drug. And then crack cocaine. So if you're white, it's crystal meth. If you're black or brown, it's crack. And none of these are hard and fast rules, by the way. And so why using drugs that you smoke increase your risk of HIV infection? And it's because that when you get very high, you lose your sense of judgment. There's a lot of sex going on. There's also trading sex for drugs that goes on. And so we have yet to see the effect of heroin in this area, but it wouldn't surprise me that it starts coming. As you say, the rates of heroin abuse are going up. And as the federal government cracks down on the use of prescription opioids, you know, it's much harder to get an opioid and to keep getting, particularly on a long-term basis. A lot of people are going to heroin because it's readily available and it's cheaper. Although I had one patient tell me once that, you know, I can stop at any gas station along Seawall and get some crack. But heroin, you got to know people. So it is on the island, and we see it occasionally, but not very much yet. And, yes?
So those new HIV-infected individuals,
Uh-huh.
are the type of infection they're having kind of like resistant to the drugs that are supposed to be helping them? Or
In some cases, we see it. You know, the national numbers are about 11% of people have some measure of resistance to some drug. In terms of people having resistance to all of the drugs, there have been a few cases reported, but that's it. So we're in good stead that way, and we're moving away from the drugs where we're already seeing resistance
Yet
to.
they are naive, meaning that they haven't really taken the drug, they are just
Right. Newly infected, we see about 11% of the people, you'll see something that says you're resistant to a drug. But in many cases, these are drugs that we're not using anymore. Yeah.
What about the prevalence of young mothers?
Yeah.
Teen mothers?
Yeah.
Like,
Yeah, but still very low. Still very low. And in fact, you don't see it very often, and there's actually good systems to take care of them. In fact, UTMB is one of the centers of excellence in the state for that. And so, you know, if you look at places to go, you know, if you look at rural East Texas, it's UTMB. You know, Houston, Dallas, San Antonio, right? And women who go into those programs, don't come out with HIV. So that's a really good thing. The number of perinatally infected HIV-infected children in the United States is virtually zero. There's a few every year. But pediatric infectious disease is basically going away as a specialty because there's not new infections and all the kids are growing up. You know, we're starting to see them in our clinic. So they're not children anymore. Worldwide, it's still about a third of infections are perinatal. So it's a serious problem. Okay, I'm getting the high sign. Lee, you get the last question.
is that drug only available in the US?
No, these drugs are available all over the world. And the United States government, it's been pays for a lot of it through something called the PEPFAR program, the United States President's Emergency Plan for AIDS Relief. It's been called the most important thing George Bush did that he will never be remembered for. And that's true. We're going to remember him for the wars, and historians will all talk about that. But quite frankly, he set up this program to treat HIV. He deliberately did it in a way that was non-political, and it's been an amazing success. And so, PEPFAR, PEPFAR. Okay, for that, we'll need to stop. And thank you all very much. Thank you for coming out.
If you want CD, have it signed in.